All right, everyone, we'll go ahead and get started. Good afternoon. Hope you're all well. Thank you for joining us for today's webinar. My name is Karen Bell, and I'm an Associate Director for Partners for Advancing Health Equity, or the P4HE Collaborative for short. We are a national research learning collaborative that aims to bring together various sectors that are working on health equity, including government, academia, community-based organizations, philanthropy, and the private sector. We are based at the Celia Scott Weatherhead School of Public Health and Tropical Medicine at Tulane University, and we are sponsored by the Robert Wood Johnson Foundation. Here at P4HE, we convene these sectors to work together to better understand critical issues related to attaining health equity. One of the ways we do this is by providing spaces for activities to engage with these groups in insightful conversations on timely topics and to promote actionable solutions. During this quarter, our level setting dialogue introduced a working definition of organizational change and established a foundational understanding of how it impacts health equity. Participants at our interactive learning session refined and co-created the definition and framed organizational change in the context of health to inform today's discussion. In response to your feedback, the updated definition and framing emphasize what an organization means and who is involved, a focus on centering the community, and the intention to enhance equity both within an organization and beyond. Participants in our interactive learning session shared challenges, innovative solutions, and they identified needs for next steps. Our workshop sprint, which took place in August, offered insights into collective decision-making and strategies to shift power dynamics for organizational change. In addition to our live programming, P4HE authored written products to provide examples of and useful resources for creating organizational change. Today, we will go beyond our shared understanding of the importance of creating organizational change to advance health equity by discussing how we can share power and implement organizational change to improve health outcomes for all. The goal of today's discussion is to outline specific action steps that individuals, specific sectors, and cross-sector collaborations can take to advance health equity through power sharing, organizational change, and culture shifts. So before we hear from our panel, we want to hear from you. As always, our whole thing, this whole project is powered by you. So you all have valuable insights on health equity, and we want those to drive today's conversation. We will be using Mentimeter, which you can access by scanning the QR code on your screen, or by going to www.menti.com on your browser or mobile device and entering the code 85528063. So once you're there, you can give the thumbs up so that we know you're there. I'm actually going to log in myself on my cell phone. So menti.com, and then type in the code, which is 85528063, or you can scan the QR code on your screen and give us a thumbs up when you are there. All right, so I see a couple of thumbs up, and I expect that to keep increasing. All right, so our first poll question is, what specific action should we, as the health equity community, take to implement organizational change? So this, you can do any type of response that you want. You can do multiple responses, take your time if you want to, but what should we, as the health equity community, take to implement organizational change? What actions should we, as the health equity community, take to implement organizational change? All right. You can spend some time. You can think about it. You can even refer back to some of the documents that we have on our website if you have participated in our previous offerings for this quarter, think about what we have discussed and learned so far. But I see some responses rolling in. Okay, I see a couple of things that are shared: share power and share resources, honesty, be strategic, advocacy, resource mobilization, work with policymakers at the state and local level, promote transparency, work in marginalized communities, seek to find buy-in from the organizational leaders, from the start, so that the boots on the ground ideas can be propelled forward in a smooth way. Okay. Listen, learn, and leverage. I love some alliteration in there, so thank you very much for that. Listening to the community, being more accessible. Authentic community engagement, not just performative community engagement. Okay. We see buy-in here again from leadership, being strategic. I can't remember if I already said that, but it's coming back to me. All right. So we see a lot here. So you have a lot of ideas about what specific actions we should take to implement organizational change. I think we can go to the next question though. And it says, what tools or resources do you need to engage in these actions to implement organizational change? And I'm hoping I don't trip up on the term organizational change too much, but what tools or resources do you need to engage these actions to implement organizational change? Okay, so again, spend a little time thinking about your response. You can put in multiple responses. All right, I'm going to contribute as well. And all right, we see some responses rolling in. Okay, staff, a different set of leaders. I mean, if you want to get straightforward to it, people, the leadership and staff who are open to change. So either a different set of leaders or leaders who are willing to change. Funding, time, money, capacity building, leadership that is committed to health equity, genuine and equitable partnerships, tools and training for members of the community to lead and implement change. Okay, communications and messaging toolkits, trainings. I can't remember who is in charge of the slide, but could you scroll up actually? Sorry. Okay, thank you so much. Okay, leadership buy-in, time, money, and capacity building, collaboration. Okay. All right, so I'm seeing some agreement here, even though we have disparate answers or different answers. They seem to be, at least for some of them, multiple responses with similar answers. Okay, so thank you all for responding. We're definitely going to keep your responses as a part of our discussion. As always, we're excited to have you here collaborating with us, and please continue to share your thoughts and comments in the chat throughout today's discussion. So I want to introduce our panelists. First, we have Greg Kotzbauer, who is the CEO and head of product at My Brain Health. Then second, we have Elizabeth Waitzig, who is the founder and CEO of Change Matrix. And then lastly, we have Jonathan Cohen, who is the Director of Policy Engagement at the Institute on Inequalities in Global Health and the Faculty Coordinator for Continuous Learning for Anti-Racist Culture Change at USC. Okay, Jonathan, you have a very long title, lots of positions, but I'm excited that you are here. I'm excited that Elizabeth is here, and I'm excited that Greg is here. So what I want to do to get us started is that you all are doing all different types of things. And so I was wondering if you could describe what you do and talk about the importance of organizational change for health equity with regard to what you do. So let's just go in alphabetical order. So Jonathan, do you want to go first?
Thank you, Karen. Hello, everyone. So, I am a professor of global health and human rights at a medical school. My journey to organizational change really comes from what we hear from our students who want to see greater attention to equity, particularly racial equity, in their education, in their classrooms, not only in what they're learning, but how they're learning it. And in response to that, I've had the privilege, as you mentioned, of designing and co-leading a fellowship program for faculty and students at our School of Public Health for how they can embed principles of anti-racism into all of the work that they do with students. That could be everything from teaching to advising to mentoring to career counseling and the myriad ways that we interact with our students every day, all of which can be informed by principles of equity and anti-racism. Thanks.
Great, thank you for that summary and introduction. Greg, do you want to go tell us what you do and how organizational change is a part of health equity for you?
Yeah, thanks everyone. Hi, it's wonderful to be here and discussing this such an important topic. My perspective today is really something that I got engaged in about 8 years ago or so, 7, 8 years ago, and that is working with the health system to engage their community to make sure that we're aware of the needs of the community and can serve them in a way that's most important to them. And so for my what the perspective that I'm bringing is engaging a board that is disconnected hospital system, a large hospital system, billion-dollar hospital system, and engaging that board that is disconnected from their community and wondering, how do you even talk to your community? What do you do? Where do you start? How do we even think about them? And not just that, but then how do you even get the momentum at the board level, at the executive level, at the physician level, to really believe in that engagement and to believe in the importance of thinking outside the hospital walls to caring as opposed to only curing, and the challenges that come with that and the otherness that often happens in those initial discussions. And how do we break through that? As one of the polls was talking about, what are the things we think about? What are the barriers? What's really the inside thinking of those boards and physicians? And what are some of the really startling comments that you hear when you're engaging at that level? And then what are some of the simple steps we can take to really make the cultural shift that we need to see people as humans, not just, paying patients or not paying patients in some cases? And how storytelling can make a big impact, and how persistence can shift the minds of some of the skeptical hospital leaders who truly only think about, not only, but most of the time think about the bottom line. And that is their administrative responsibilities and that is the reality. And so how do we fight through that and make sure that there's a humanness to caring, even in large hospital systems that are truly thinking about margin and finances?
So always the W, used to be a Z. Thank you so much for having me. My name is Elizabeth Waitzig, as Karen said, and I am the CEO of Change Matrix, which is a small consulting firm that's been in existence for almost 20 years. We've been focusing on motivating, managing, and measuring meaningful change to improve lives. And really, what has been sort of the hallmark of the way that we work is how the ways in which we engage community. And so we think a lot about conditions for health and well-being within community, but how do we make sure that community is driving, defining those conditions for health and well-being? How do we make sure that we are, while we're intervening at the system level, the impact is felt at the community level? And this means that while we're working, we're centering community as we co-create. We understand their conditions. We're learning from them, and we're co-designing and co-refining. There is a specific initiative that I really want to talk about because we are partners with P4HE on a bundled initiative funded by the Robert Wood Johnson Foundation, and that's called Transforming Academia for Equity, that is specifically focused on health equity research. And so a couple of years ago, we were able to work with 7 schools and programs of public health. We invited them to work with us, USC being one of them. Excited to have Jonathan here. What we were embarking on a couple of years ago was really trying to help folks who are working within a system to see it and work to dismantle it. I mean, just imagine that for a moment. You're part of a system, you've grown up in that system, you've aspired to be in that system, and now we're asking you to think critically about how that system challenges the very notion of achieving health equity. And so we've asked folks, for example, to think beyond the typical aims and deliverables in a grant process and think about vision and iterative journeys and process to find inclusive environments for researchers, primarily researchers who are early career from diverse backgrounds. And ultimately, the goal is how do we move towards inclusive and sustainable environments to support those health equity researchers, because health equity researchers will get us to health equity. And so it has been a little bit different in that we've taken a shared leadership approach. And I'm sure we'll have an opportunity to say more about that, but I'm looking forward to it. Thanks, Karen.
Thank you all for, first of all, explaining what you do. Hey, like I said, we're coming from this topic or coming to this topic from multiple angles, which I really appreciate that level of diversity and cross-sector discussion that we're going to be able to have. I wrote down a note that occurred to me that I figured I should also ask before I get to my list of questions that I've been given. And it's in response to the poll that was shown, but also came up for me while you all were explaining how you're thinking about this and what you're doing with regard to organizational change. And what came up for me was the leadership buy-in. So Greg, you talked about change sort of being driven kind of from the outside of the institution. And then Jonathan and Elizabeth, the change seems like it's from the inside of the institution, but also like the power dynamics. Jonathan, you're talking about students driving the change. And I was just wondering what you all thought about how who wants that organizational change really can shape how things go, how leaders buy in or they don't, and how you get them to buy in. I guess we could start with you, Greg, because yours, how you described it was we need to change how we look at the community and look at patients. So I was wondering what you thought about leadership buy-in from your perspective.
Yeah, and I'll just speak very frankly about my exact experience in this particular context, and because sometimes it can be a bit shocking. Maybe sometimes we make the assumption that it's not, maybe it's not always shocking, but so I think there's a couple things, right? We understand the importance of leadership buy-in, right? But regardless, we always have to pay attention. How does the story go? If you want to understand how someone's going to behave, understand how they're paid. And so you can have leadership who says the right things. They want to do this or they believe in it. But when it really comes down to it, unless you can create a humanness to the mission that you're trying to accomplish, particularly with a focus on health equity, and in a case of making sure that those who are not served today can be served in a human way, and not trying to, when we're doing this, at least my experience was, and this is a system that traditionally has been, I'm giving one example, committed to the community, but nonetheless, it still was about the bottom line. And so there was a lot of skepticism, a lot of nodding heads. Yeah, let's do this. But there was still a sense of otherness about what we were doing. And so I would present to the executive board, yeah, okay, just don't ask me for any money, right? This is great. Just don't ask me for any money. And while they were still trying, the next conversation, the board meeting was talking about how they were going to communicate to the community they were doing things for the community, right? Because they were writing off unpaid bills and things. So, but then it was that, and it was, well, go out there, Greg, and talk to them and just help people feel like they're being engaged. So this performative component, right? And so, and it's pretty startling, right? And when you hear this from the board, and it's they have, and sometimes these hospital systems, you have to realize, right? There are executive boards, there's community boards, there's physician boards, and every time I would talk to every one of them, physicians sometimes would say, well, what are you going to do about people who don't eat well? I see people in these communities just eating bad things. And so here in this context, right, you realize this is not about there's a bigger fight to be had. And so for me, what became clear is you can't talk about, well, we're going to help with hospital savings, or we're going to have an ROI on our work, or we did those things. But what for me found to get the most traction was storytelling and telling. And when we would do work in the community, and we would go back to board and talk about our work, and it was always about pictures. It was about people's voice. It was about what their words, not your words, and what mattered to them, and creating this sense of breaking down the otherness that often happens, because most of the executives you talk to, a lot of the physicians necessarily, they aren't out in the communities and seeing the challenges that individuals in their communities face. And so the storytelling part was able to break down a lot of these otherness barriers and create that sense of humanness, and was able to, over time, through pictures, through patient writings, through stories, really get this sense of care, a care model where we were including the patient voice and the perspective of individuals, we've called for a long time social determinants, to get that embedded into care as a standard way of working. But for me at least, it took years. Now, years later, they have some of the work that we did where we're actually capturing social determinants of health in primary care and even in hospitals in every visit. It's a standard way of working. And we have 50,000 records of patients telling us what matters to them from a non-medical point of view. And so, but it took years and years, starting with a first few administrators, one board, a second board, starting with one physician and one primary care practice, going a few months with that, getting a few stories, having that primary care doc talk to the next primary care docs. Okay, then you go to the next primary care practice, and on and on. And now, with 20 practices later, it took years though, but it took that persistent storytelling, putting the human first, because you hope that that's why people are in healthcare. But never overestimating what people say around sometimes the performative language. Yeah, that's meaningful. Yeah, we should do that. Yeah, we should whatever. But knowing that in the end, they're still most time in healthcare focused on the bottom line, and they're not going to do anything that's going to risk their job and or the organizational financial performance.
Okay, all right. Yeah, thanks, Greg. I think that this also brings up something that can be related to Elizabeth, the work that you do, and probably Jonathan as well, is the um, diverse identities and experiences that need to be there within leadership in order to have that buy-in. So, Elizabeth, could you talk about that a little bit?
Oh, I can. Thanks for the opportunity. We started TAE believing that there was formal authority. We know there's formal authority and informal authority. There's formal leadership. There's informal leadership. We come with the belief that everybody is a leader. Every single person, from whatever chair they sit, students, faculty, early career faculty, folks from a variety of experiences are leaders. And so leadership buy-in, that's always a term that gives me pause, because then we're talking about having people who have this special role and they have more resources and they have more power. And if they don't say yes, then we can't do things. And that's actually not true. And so if we really think about engaging people from diverse spaces with diverse identities, diverse experiences, ideas, into a shared leadership group with, and this is really important, a shared vision. because what keeps a diverse group of people together in a sort of movement type of an effort to create organizational change, what grounds them throughout their diversity is that sense of shared vision. I can think of one of our schools that is part of Transforming Academia for Equity that includes the dean on their shared leadership group. And so you have administrative leadership, you have faculty leadership, you have early career faculties, and those folks who are the most articulate and passionate about what they want to see in this inclusive environment are the ones that are exercising leadership within that group. We've done things like, I wonder if people have heard of this before, like taking equity, diversity, inclusion, and belonging and defining them. What is that? What does the word diversity actually mean within the context of the school? That is the work of shared leadership, because then they bring those definitions back to student orientation and say, that's what this school is about. How does that sit with you? How do you, what do you expect based on this definition of equity? So that grounding work of a shared leadership group sometimes feels a little, you've seen the eyes roll back in people's head when you say, we're going to create a shared vision. Nobody loves to do that, but when they do it, and if they use it, it can be that the glue that holds them together. And you cannot exist in shared leadership facing complex, dynamic challenges, as equity always is, without diverse voices. I have never seen organizational change happen because the person at the top said it's going to happen, with the exception of one time when a judge said the ship is sailing and you either get on board or you don't. And that was enough for all of us to get on board. But by and large, you don't see complex change happen because one person said it should. And if it does happen, it's not sustainable because they will leave. So
Yeah, thank you for bringing up the concept of shared leadership. And I'm wondering, Jonathan, for you, if that was something that came up when thinking about how to design these efforts, particularly for students who are, the ultimate endpoint, I guess, for the context in which you work. What do you think about that?
Yeah, I relate very much to the concept of shared leadership that Elizabeth articulated. The organizational change effort that I was involved in was essentially a semester-long fellowship program for faculty and staff who wanted to embed anti-racist principles into their work with students. And what it ultimately was leadership development. I mean, the modules that they went through, which encouraged them to reflect on their own privilege, to think about how racism and anti-racism apply to our institution, to design projects that apply those principles to their work with students. Ultimately, that came down to developing them as leaders. And it very much assumed the kind of shared leadership that Elizabeth is discussing. I think when it comes to buy-in of senior administrative leadership, which we all know is an issue, I would say a couple things. I'd say, first of all, that the success that we had would not have been possible without it. And I can give very concrete reasons why that is. For one thing, just having our senior administrative leadership tell their own stories, coming back to the storytelling point, and share their own journeys was immensely empowering for the leaders among faculty and staff that we were trying to develop. I thinking about my own story, there I was, a white faculty member leading a leadership development program on anti-racism. Were it not for my senior administrative leader, my chair, who is Black, um, saying specifically that what is valuable about this program is that a white faculty member is leading it and taking responsibility for issues of racism in our school. Had he not done that and publicly stated his faith in me, I think I would have had a much more difficult time doing this. So it was essential. But for a lot of the reasons that Greg has pointed to, it also was not sufficient, right? Because senior administrative leaders also exist in a structure. They exist in the same structure that, as Elizabeth said, we're trying to dismantle. So they are not all powerful. They cannot by fiat change the compensation and incentive structures at a university so that work on racial equity is compensated in the same way that work on teaching or biomedical research or patient care is compensated. They also work within a system. So necessary, valuable, and insufficient at the same time.
That I think that's a reality that I had not thought of until I really, got in these systems myself. And you all brought up various challenges, including something that came from the poll, money, funding. Who's going to pay for this change? And also like the power shifts and the power dynamics, and also thinking about those who have power that we think they have power, they may not have as much as we thought. um when we did our preliminary or our previous activities on this topic here at P4HE, we came up with these, issues, strategic planning, power sharing, and shifting the culture, which has also been mentioned. But I'm wondering, even given what you all just shared, if there are any additional challenges that can arise with doing organizational change and how we can combat them. So if there are additional ones, please share. But if there are not, do you have strategies to combat the challenges that you all discussed?
You said something really quick. I don't want to stop. That was really important. I think that surprised me, but it didn't surprise me, is you talked about, we understand the financial incentives that, for example, administrators operate under and the pressures they feel. But the other thing that was interesting to me, for us to recognize, is there are some people who want to be, not the hero might not be the right word, but want to be a lead. But you have to understand their motivation around who would they have to face down, quote unquote, to make change happen, right? Who would they have to talk to? And for example, there are administrators who, and for sometimes good reason, sometimes not, want to make sure that they don't speak too directly to physicians, and so they're will tap dance or tiptoe. And again, sometimes maybe that's needed, but the point being is that you can get all the feedback you want and you can have buy-in. Like, for example, this one initiative I was talking about, I had buy-in from the CEO, the chief financial officer, the chief medical officer, the chief strategy officer. All of them were my sponsors. So you think, can you get any higher as far as having essentially your executive leadership team? But when it came to change with the physicians, it was, Greg, you're on your own. So, and if it didn't happen, they didn't have, their hands were like, we tried, or we thought it was important. And so, luckily, maybe because I was naive, right? You just say, gosh, this is about caring for people, right? How can this not go well? And we'll fight the fight. And but that's one reason why it was so slow in creating these human stories. This is what this is what they received. This is what they expressed. This is how their life changed, like one person at a time. And this one physician said, this is great, right? And so point being is that you can have all the words you want. You can think you have the top-down leadership, and what's been said by Elizabeth and Jonathan, but sometimes that's not sufficient. You have to understand the motivating factors behind these people beyond what it appears.
Yeah, I totally agree. I was just gonna say really fast, Elizabeth, that we need to do more power mapping. Like, it's not just like those people with the titles who actually have power in these scenarios. It's people that we would not think of. So I apologize. Go ahead, Elizabeth.
No apologies necessary. You're absolutely right. Like, we think we know who has power. We don't always know who has power. I think this, Greg, what you're alluding to that I'm really resonating with is is the need for relationship in all of this. So
Yeah.
when we talk about shared leadership, we don't talk about a bunch of people coming to a meeting so that they can have their voice heard. What we're talking about is a group of people who have shared who they are. They have shared what they hope to see and created a shared vision and all of that. They know that sometimes they make mistakes and they can come and be wrong in the space of that meeting or offer an idea that is not shared by everybody. There's an element of risk in shared leadership and in organizational change that if we can coalesce around that risk together and with trust being the foundation, we can actually make things happen in a much more powerful way and sometimes in a quicker way. But this idea, again, this idea that one person can move this forward, it's not going to happen. But if we come together, not just because we're coming together, but that the collective is built on the relationships, the common vision, the shared data, the narratives, and move the entire organization forward together, that can overcome that sense of risk and vulnerability and potential loss that people will often fear, either when it's their own individual loss or embarrassment or scarcity mindset or whatever fear gets in the way of actually being able to take a risk to move forward and change.
Yeah, I thank you. The only other challenge that I would want to highlight in addition to, the money issues, the buy-in issues is um the work of organizational culture change can be very, very draining for people. Um, you know, I often describe people who are engaged in culture change work as kind of swimming against a current. It's just more exhausting. It just takes more energy to go the same distance when you're swimming against something. And how I describe the work they're doing is we're actually trying to change the direction of the current so that when you're swimming, it's with you, and all the people who you're trying to change are the ones who are having to work harder. And in order to do that, I mean, there are a couple of strategies. You have to, I think, have a very compelling vision of what the culture is you're working towards. Why am I making all these sacrifices? What is it that I have to look forward to? So, our anchor, our lighthouse, our beacon, if you will, was this definition, this vision of what an anti-racist culture in a school of public health looks like. A culture where everyone has equal access to opportunity, a culture where diverse people feel a sense of belonging, a culture where students are provided with pathways to counter the injustice they see in their lives. That's a vision that's worth working for. It's a vision that's worth getting a little tired for. But it also requires a lot of acknowledgement, So acknowledging that, yes, the same people keep showing up at every meeting, you know? Um, yes, there's no financial incentive for doing this work right now. Just acknowledging it and then providing a lot of, as Elizabeth is alluding to, relational supports. So that could be your peers. We provided individual coaching to our fellows. It could be a mix of peer-to-peer and one-on-one coaching and group workshops, but I think those kinds of relational supports are a really important tool for overcoming the fatigue.
Yeah, thank y'all for describing the challenges, but also ways to counteract them. Because I think that particularly for this topic, and I've done a bit of research on organizational change, but like in local health departments, and everybody's able to identify the problem, but not come up with, solutions or approaches at least to counteract the problems. But one thing that came up in the work that I had done and is coming up for me now with this conversation is that we have uh, represented here two sectors, I think, academic and healthcare. But what's sticking out for me is like the role of community, like people outside of these institutions. And I'm wondering how, if it has, how that has impacted either the need for organizational change or how organizational change has been done. Again, Greg, I would see it probably more clearly with your situation, but I'm also wondering from the academics or academic points of view how that had come up. So I guess Elizabeth and Jonathan, but then also Greg, if you have anything to share, please go ahead.
Yeah, I'll just say real quick, and then you all can. And one of the things we realized, right, is that we needed a coalition outside of just the executive sponsors. And what we were working towards is having so much movement that the doubt or the performative language that, comes from the board was undeniable. And so one of the first things we did, and maybe right or wrong, is we didn't really ask for approval much, right? We just went and talked to people in the community and asked what they needed, what mattered to them, et cetera. And then what sources they used, what sources they didn't have as far as for support goes. And for the organization that were in the community that were struggling, of course, because of the lack of funding, but they were there, as we partnered with them, and we would have at least monthly meetings, and we would create data systems to say, these are the things that we recognize that our patients need and said they need in the community. We're going to do referrals to to you. Let's track them together. They were manual, right? I know there's some technologies now, but they were very manual and just, phone calls, texts. Make sure we're here for each other, even outside of the system where a lot of the, particularly these, our healthcare needs start, right, in the community. And so just that relationship building also, it gave a lot of feet to us, or whatever the right word is, wind in our sail, within the community, and help care for people. But then also showing the hospital system that, oh, wow, you all are creating connections that we didn't have. That's good for us, in some way. So it was just that openness and transparency with our community partners, and just saying, we're doing this because we care and we want to care with you. And that helped us a lot as far as getting momentum.
So I think you're right when you say, Dr. Bell, that academia is maybe not as easy a place to talk about in community engagement. I do know, though, that are a couple of the grantee institutions that are part of Transforming Academia for Equity very much have engaged the community in the visionary work, in the plan for change, in defining what success looks like. And part of our work at Change Matrix is also with something called culturally responsive and equitable evaluation. And so it's mostly focused on the ecosystem of evaluation and funder, but it's very much a part of this knowledge building effort that I think academia, research, evaluation all contribute to. It's all about building knowledge. And so part of that CRE, culturally responsive and equitable evaluation work, is really focused on the community designs the plan. The community helps develop the measures and the instruments. The community is analyzing alongside. We're not doing anything if we're not doing it in partnership with the community. The challenge to all of this for the systems, including probably academia, is that it takes time. And so one of the things that, and it does cost more, and it's more valid data, though. So what a part of our organizational change strategy is really helping people understand that the benefit of building knowledge in a more community participatory way is that you get better information and the outcomes are better.
Yeah, I'll just say quickly that we were lucky in a way. Before USC joined the Transforming Academia for Equity cohort and launched the program that I'm describing, the university had a decades-long track record of deep community engagement, from participatory community-based research to dozens of pathway programs and benefits to employers from the community. So that was less the emphasis of this particular program, although we did include some community components. So there was a module for our fellows on community engagement in teaching and that kind of thing, but it wasn't the focus because we had made such strides in that area already.
There are two comments in the chat that allude to sort of the makeup of people, or the probably just racial and ethnic makeup, but maybe not, of the organizations that you're referring to. One talks about how their daughter, who is Hispanic, graduated from NYU Medical School, and at one gathering of her class, she asked people whose parents were doctors. Most of the room held up their hand. If medical organizations, or if people who are in medical organizations come from health educational institutions, how can this be changed, especially in the current political atmosphere? And then someone else is talking about who is and who is not on the board. So I would imagine that we could ask a broad question about, given our political context right now, how are we thinking about doing these types of organizational changes where we're censoring diversity?
I'm thinking about right now is I just heard Brian Stevenson say on a New York Times interview that he had the same thing happen to him when he went to law school in the 70s, right? That they all had how many of your parents were lawyers? And they all raised their hand except for him. And he went away thinking, I don't belong here. I do not belong here. And it took somebody in his life, I think it was his mother actually, who said, you belong anywhere that you are. It's that. So I think about that, and I think about another one of the institutions that participate in transforming academia for equity, who did this really bespoke, supportive, they called it the Rooted Academy. And it was a really amazing opportunity for earlier career faculty who didn't necessarily have a background of education, but it could include coaching, professional development, teaching, mentorship. And to hear these folks speak, it wasn't about I learned to be a better teacher through this. It was, I felt like I belonged here. I felt like the students were ready for me because I had a little bit more confidence because somebody in the institution took some time to make sure that I felt comfortable, confident, that I had a place to go if I had questions. Like it's like we can't replace parents. If you don't have parents that went to med school or law school, you can't do anything about that. But what you can do something about is what are the things that you could put in place that people choose, that they find value in, that really help them feel a sense of not just belonging with the people, but belonging in the institution because they should be there. So what are we doing about that within the environment? I think is a great question.
Yeah.
And and can
Sorry.
transcend this political environment because
Yeah.
at some point it is what it is, and we have to do what we can do to say, you think what you think and we don't care.
Mm. I I'm actually, somebody just put a question in the Q&A box that kind of relates to what you just said, but also it's not really, they posed it as a question, but I actually think it's a pretty strong statement. So I'll do it as a statement. So instead of thinking about simply partnership, but someone actually approaching you, meaning you all working in institutions who are working on organizational change, approaching you from the community with an idea first, and they are inviting academia and or healthcare to follow their idea and use their tools to help move an initiative forward. In this way, the community is the lead, and healthcare and or academia contribute their tools to support. This would indeed redefine power sharing. What are we thinking about that statement?
As someone who, so I work for something called the Institute on Inequalities in Global Health, and we have long sought to disrupt the hierarchies that exist in global health research partnerships in precisely the ways that you're describing. So I totally agree. I think that it comes up against some of the same structural challenges that we've been talking about, with the exception of very few funders, the Robert Wood Johnson Foundation being one of them. It can be very hard to persuade funders that a kind of elite academic institution should be the sub-awardee on a grant that goes primarily to a community-based organization. And I really do applaud RWJF for flipping that script. And I hope the National Institutes of Health follow suit, and all of the other major funders of health sciences research, because it's of course exactly what we need. But so many of the systems and incentives and funding flows prevent that from happening. Thanks.
I agree. But I do think that that is a hopeful way to go about it. That's how I do most of my community engaged work, is through it being initiated by the community. This is a cross-sector Robert Wood Johnson funded collaborative that we have going. And I wanted to ask you all about cross-sector collaboration for community, or excuse me, for organizational change. Like, is that something that you've ever thought about in the work that you're doing, or maybe the work that you want to do? And cross sector can mean anything. It could be working with businesses, working with funders, working with community-based organizations, anything that comes up for you with regard to cross sector collaboration. And we have like 6 minutes left. So if you have any response, please go ahead.
I have a really quick one. In transforming academia for equity, we are fairly focused on academia, but we talk about departments, schools, universities, community. So there is some cross sector if you think about it that way. We also work though in human services systems, working with mental health agencies, education, community-based organizations, family advocacy groups. And when we speak about shared leadership for organizational change, especially if you're taking an expansive view of organization, there's no way to do it without the cross-sector collaboration, because otherwise you get into your own bubble, your own way of thinking. And to take the time and have the courage to listen beyond that is critical. It also takes coordination, though. There has to be infrastructure for cross-sector collaboration. It's only an idea, and a good idea, unless you have somebody that's coordinating it, you have people that are expecting it, you have a way of structuring it, and then you maintain intent and vision behind it.
Anyone else have comments about cross-sector collaboration? Because someone in the chat mentioned belonging, so I wanted to lift that up. So someone says belonging goes both ways. Going into communities as the expert is not always welcoming to the receiving community. So I think belonging, especially thinking about the work of Brian Stevenson and other leaders related to this topic, or related to the topic of equity, I think broadly belonging is something that comes up. So have you all thought about how belonging is important to organizational change?
Can I ask Greg real quickly? Because you were talking about the physicians, and it kind of occurred to me to ask you, in your experience, how do physicians and hospital administrators, practitioners, how do they view themselves as members of the community? How do they see themselves in the community?
That's a pretty charged question, right?
I know.
Obviously there could be many factors. If a physician is serving in a community they grew up in, they're going to have a very different perspective and sense of commitment to the people there than maybe someone who doesn't. Not to say the other physicians aren't as committed, right? But when you have a sense of grounding, right, where you've grew up, it's very different, your commitment level. So I'll just say, for me, I haven't come across anyone, and I've worked with probably 100 health systems, that people don't care, right? It's not about that. But going back to the point of, to understand how someone's going to behave, understand how they're, incentivized or paid, it's very much the reality. And for example, when I first started talking about caring for the whole person, caring for the human, with physicians, and some of them were like, I'm not going to do it. I'm too busy. It wasn't like they didn't really understand it, but it was, again, the system is holding them back, and they're not paid on that. They're paid to cure. And so it was very distant sense of, yeah, I'm part of the community because people come to see me, but I don't really do anything in the community. I don't really know what's going on in their lives. I hear about it. Maybe we have a community health team that goes and does that, right? We do some good by getting grants or whatever. I'm meaning from the administrator perspective. And so, and physicians, but part of the reality is that they would not only not be part of the community, and because the system wasn't letting them ask the questions about what matters to you, right? What matters most to you, not and what are this, to try to understand what the circumstances that are leading to why you're here, whether it be money, transportation, food, your electricity bills, all these things, right? That often lead to poor health, because they didn't have time to ask those questions. And they didn't have any support to do anything about it. So I literally had physicians say, I get it, Greg, that's all good, but I can't do anything about it. So I am not going to ask those questions. I'm not going to ask, do you have enough food, or do you have transportation, whatever. And so what that did is, just getting back to your question, is it keeps them distant from the community, right? Because if they felt like they were so busy and in this cycle of trying to care for people within the system that paid them on a per visit basis, and they had to see so many patients per day, they didn't have time to ask this question. So that ultimately, disconnects them, unless they're going to, after they chart, late at night, they're going to the community and do that work. And there's limited time for that. So it's very distant for everyone. Yeah.
It sounds to me that and something that's in the chat as well is that we need to change systems fundamentally,
Right.
instead of focusing on potentially surface level organizational change. So with that, and I'm looking at the time, I'm so sorry. This was a great discussion. I really appreciate you all. Thank you so much for being here, and for the work you do, and for sharing your thoughts about organizational change toward health equity. So really, thank you so much. We are going to close the webinar by asking the audience if you have any thing that you would like to share. There's a survey for you. You can use the QR code to fill out the survey. The link is also in the chat. Also, we will mention that in December, in Montgomery, Alabama, we will be having a summit. Stay tuned for registration information. For the latest information on the collaborative, including upcoming events and new health equity resources, please visit our website and sign up for our newsletter. Connect with us on social media to access shareable health equity content and engage with relevant topics that you need and that you want. So thank you so much and have a good day, everyone. Bye. Thanks.